And I'm shocked at the number of trainees that say, we never have a one-to-one tutorial. What the exam does is it shines a light on that differential attainment. If people are not safe with our patients, they're going to get in trouble with the GNC. My job is to make sure we level the playing field. We demystify exams, that the good doctors, the safe doctors, pass.
Hi, my guest today is Professor Anwar, is GP in East London. If you don't want to miss the insider tips from an RCGP examiner, then make sure you watch this until the end. Could you take us back to what made you go into medical education and assessment?
I came into general practice through a very circuitous route. Jobs were hard to find in the 80s, and I did genetics for a while. And then when I came to London as a GP, because a friend of mine had a job going, I asked the local BTS, can I sit in? I've been doing genetics for 3.5 years, and it'd be nice for me to refresh myself, even though I've been doing out of hours. And he said, oh, why don't you set up a residential course for trainees? And so I became, in those days, we used to call them course organizers. They're now called PDs, aren't they? And so at Whips Cross, I was a course organizer. I met as course organizer, other course organizers in North Thames in those days, and a couple of them were examiners, and they inspired me to apply. Because prior to that, I thought, oh, you have to be very academic, etc. But the great thing of the MRCGP exam, it is they want jobbing GPs who have a passion for promoting patient safety.
Tell us a little bit about your journey in becoming a trainer and actually progressing in medical education.
I went to a practice that had lost its training status many years ago, and it took me about 5 years to get the practice to a state. In those days, we used to summarize notes, make sure systems are in place, and we used to have quite long visits, accreditation visits. So but by 1996, I'd become a trainer, and I must say, since then, I'm still a trainer now, and it's over 35 trainees I've had. They've actually kept me up to date. They've kept me on my toes. You can't relax, especially when you have very clever trainees, cleverer than me. They'll keep me on my toes to make sure I know that enough to keep my patients safe. Because at the end of the day, you've got a role model. And one of the things about role modeling, by the way, is all examiners, and I did it when I became an examiner, do the AKT exam. So, candidates can't say, oh, examiners, you don't know the pain you go through for the AKT exam. No, I do actually. I've done the AKT exam, and I think it's important that that is a good principle, that examiners do that. So yes, and actually I became examiner in 96 as well. So I'm one of the oldest ones currently, and I really enjoyed my time on the panel. I called it the annual Prozac, because you meet like-minded, enthusiastic GPs who aren't run down by the politics and the turmoil, the frontline hard work that everyone does. And meeting colleagues, it's quite helpful. And I'm proud to say there's about a dozen or so examiners that were my ex-registrars or ex-appraisees. They're examiners, and I'm glad I'm able to infect them. Maybe I infect you, Erwin, and you'll become an examiner in a few years.
So I can see that you have a passion for doing what you're doing. Recently, the college has changed the way that the AKT is going to be assessed in terms of the number of questions. What do you think about that change?
I think it's a really good one because it decreases the assessment burden. And theoretically, there's a lot of modeling being done for the last 5 years or so, actually. And that means that the better candidates won't have to do the full 200 questions because we can make that. Because at the end of the day, exams about making sure, can we trust this doctor to be out and patient safety? So just on another note, you may not be aware, but I, with Peter Burrows, set up the induction refresher exam, which became national in 2006. And there were 3 principles behind that. One was keeping patients safe. 2 was keeping practitioners safe. Because if people are not safe with our patients, they're going to get in trouble with the GNC. And the 3rd is about reputation of the profession. So I do think the exam has an important role. But I must say, some of the challenges to the exam have been about differential attainment. And unfortunately, it's the journey that's the differential, not the exam itself. So it's a bit like someone comes and asks for blood tests and you find them to have an abnormality. It's not the path lab that's made the abnormality. They developed that thing. And I think the journey of some trainees isn't as smooth as others. And I do think, and differential attainment is one of the things I've been passionate about. And if there was any differential attainment within the process of the exam, I wouldn't be an examiner. Okay. What the exam does is it shines a light on that differential attainment. What do I mean by differential attainment? It's that consistent disparity in the educational career outcomes of different people of different ethnicities. Okay, and that's not unfair. Let's be honest. But there are many reasons for it. There may well be some individual stuff, and as you say, running the I&R exam, I have come across some of the cultural and linguistic challenges. I mean, I know one person very well. I won't say her name because it's a public thing, but she qualified in Uzbekistan. And when she was training many years ago, it was quite obvious in the old video exam, she was using a lot of the future tense. You will do this, you will do that. She was translating from Russian into English. And that translation process poses linguistic challenges, doesn't it? I see a number of doctors, and again, I'm not generalizing or I'm stereotyping, but as a generalizing thing, a lot of the Eastern European doctors wouldn't want to admit anything they don't know. So, for example, when a patient came to me and said, "You had your barnet cut," I said, "What the hell is a barnet?" They said, "Barnet fair, hair." So I could ask that, but there are some cultures you wouldn't ask, what does that mean? Because that would show frailty. So I think there are some cultural and linguistic challenges. I think there is something also about how people learn. Internationally, role play isn't that common, by the way. Medical students get role play all the time here.
Yeah.
So when they do an exam with actors, and this particular person said to me, "They're not real patients, they're actors." No. You've got to buy in to the fact they're a patient to be able to act, to be the doctor. And I think there are some of those, I suppose, jumps in their way of thinking. So they've got to buy into that. And there is something about confidence and self-efficacy. And I do think we need to think about that. I think the bigger problem are the institutional factors. There is variability in training and support. Let's be honest. By the way, with colleagues of mine, we've developed an app called CliniTalk, which is a telephone-based app. You put it between the patient and the doctor, and within a minute, it brings out the transcript of that consultation with feedback based on the SCA exam, by the way, because that's what I'm doing, to give them feedback about it. And by the way, feedback is critical. And that's one of the things that when I run TTT courses here and internationally, because I'm medical director for international at the moment, I say feedback is a very powerful tool. Used incorrectly, you can destroy a trainee. Used correctly, you can augment the trainee and they become even better than the trainer, which is what the aim should be. So, and I'm not clear that enough emphasis is given on the importance of feedback. So there is variability in training and support. Why do I know that? There are trainees that come to me that are using the CliniTalk and say, "My trainer doesn't really always have time to look at my COTS." Now, come on. If you're not going to be able to advise youngsters on the use of the one tool you have as a GP, that's your tongue, by the way. My son's gone to the dark side. He's an orthopod. But I tell you, my tongue is sharper than his scalpel. And he spends a lot of time practicing using his scalpel. How often do we practice? We don't.
Are you feeling unsure about the SCA? Maybe you don't know what to do, or you don't know whether you're doing the right thing. If you'd like to get a free copy of the SCA Blueprint, click the link down in the description below to get access to the SCA Blueprint that GP trainees have already used and passed the SCA exam. It's completely free. Just click the link down in the description below to get access to it.
I know a lot's been made about unconscious bias and assessments can be subjective. Not at the MRC. They're very well quality controlled. Having said that, you could say some of the workplace-based assessments could be subjective, because there is, and I think there's more training needs to be done with trainers to be calibrated. And again, what the Clinic Talk app does, it's not perfect. It gives you initial starter for 10 for the trainers to improve upon. And I think there needs to be a lot more calibration amongst trainers. I'm often invited to Kuwait to do some TTT courses there. And every time I go, we do some calibration, because we need everybody on the same hymn sheet where the bar is the same level. So I really do think we need to think about that. And it's only a hypothesis. I don't want to cast aspersions. I wonder whether some of the ones who fail the exam, which shine the highlight and differential, they're probably not getting as constructive or supportive guidance as they should. So I do think, and I feel quite strongly, you probably noticed, and one of the reasons I feel that way, and I spent 3 decades trying to level the playing field. I've been lucky that people like Selva invite me to their I&G SCA and AKT courses, and my job, I think, is to make sure we level the playing field, we demystify exams, and that the good doctors, the safe doctors, pass. The unsafe ones that have the enough feedback to develop the skills to be safe doctors and then pass again, because we need lots of doctors. So I've gone on and on about it, but if I'm going to, and I've thought about different attainment for a while, we need better induction and support for international medical graduates, and that's why the I&R exam includes induction. It stands for induction refresher exam. Okay, refreshers because people trained in the UK were coming back, so that was refreshment for them, but induction for international. I do think there needs to be cultural competency training for educators, so that they understand some of their own biases. Yeah, and there needs to be more targeted exam preparation, not to teach to the test, but to understand the test and learn how they can prepare better. And I think the other thing, which we'll probably talk about later, is actually for me having enough role models, mentors, and leadership development. We actually need a much more diverse role models, where we need much more support networks. I mean, I'm at the end of my shelf life, but what I'm hoping is people can see that color isn't a bar to preventing you being an examiner or an academic in a university.
Tell us about the common misconception that you have noticed among some of the exam where people don't understand it and thus lead to pitfall.
A lot of the common misconceptions are that there's one way to do it and that's how they're going to pass. So, for example, I often say to them, we talk of ICE, ideas, concerns, and equipment. Who actually talked about ICE initially? Nobody ever really knows. And they do it as a mantra without understanding what it means. And it's a bit like people are told to do certain things because of tradition. Yeah, I won't mention any specific traditions because I don't want to be accused of, being against one culture or another. But I know in my own upbringing, there are certain traditions I thought to myself, what's that? Yeah. And people do it, and people are beginning to use ICE as a tradition. Yeah. So one of the examples I tend to give people, so you've got your jumper on, Erwin, Do you feel the weight of your jumper?
You get used to it, isn't it?
Get used to it, absolutely. So you don't, but if you were wearing clothes that you weren't used to, like a sari, you would think, oh, it's falling off. There, yeah? So what I want people to do is if they come across a concept like ice, is actually say, can I own it? Or if I can't own it, let's not pretend I do it. Because if you do that, you then go through like we have a jargon in amongst them, mechanistic or robotic, where you're just going through a checklist. You're not taking notice. You know, you say, you know, what are your ideas about the headache? Oh, I think it's a brain tumor. What are your concerns? Well, I do think it's a brain tumor. What are your expectations? I do want the brain tumor removed. And then the person says, okay, now let's just, do you smoke? Without even addressing what you've elicited, because they're doing it because someone told them. And I want people to buy into things. You know, people talk about in the SCA, it's all about making the correct diagnosis. Actually, it's about assessing your holistic patient care. Shared decision making. Again, I hear candidates talk about, oh, shared, I must ask the patient, what would you like us to do? That's not shared decision making at all. That's abrogation of your duty as a doctor. I think shared decision making is about explaining your journey to the diagnosis so that the patient understands what to do. There's a lovely, my favorite author is Peter Tate. Sorry, Roger, if you're listening, I no offense to you, but Roger's another good friend of mine, but and he's helping with clinical talk. But Peter has written the book Doctor's Communication Handbook. And in that, he talks of the rule of thirds. 1/3 of patients listen to doctor and do what the doctor says. 1/3 of patients listen to doctor but don't do what the doctor says. 1/3 of patients doesn't listen to doctor nor does do what the doctor says. So 50% non-compliance already. Why? Because patients don't understand that journey to the diagnosis, to the treatment. And I think that's what we need to be doing. The other big area, and I see this in clinical practice, is safety netting. I mean, safety netting are the red flags of your differential, are they not? And if your differential does not include MI, why are you saying, in the case of costochondritis, if your chest pain is no better, go straight to A&E? Why? Where did you make that up? You're scaring people. So safety netting must be realistic. So we are getting unrealistic safety netting coming in, which is frightening patients, which is unfair, isn't it? I mean, you send a patient to A&E nowadays, they're stuck in there for 36 hours, like I was with my mum in November. You know, so, and it's not fair sending patients there. So it's about actually an appropriate safety netting. I do think it's about developing a structured consultation with a beginning, a middle, and an end, so that you've got data gathering and management that are balanced. By the way, I find some of the candidates who are not sure what to do spend the 12 minutes on data gathering. You know, that's an easy job. Medical students do data gathering. Doctors do the management, don't they? And if you're going to waste time to asking lots of data and not coming to management, I mean, more than half the marks on management. You've lost more than half the mark, haven't you? Well, no, you've got 3 domains. Of the 3 domains, it's got extra weighting, so it's just nearly half, just under half. So if you're not going to do management, you're going to, you're on your way to fail. And I do think it's about people remembering as much as possible in the SCA, they're not like real life. They're easier than real life. The case is standardized to finish in 12 minutes. So in general, 50% data gathering, 50% management. Now, there may be some breaking bad news where you have very little data gathering and a majority about management and breaking it. There may be clinical areas where the management is quite straightforward. You're going in, and there may be much more data gathering. But in general, 50-50 is what I would say. So I do think that's one thing. The other point is, you know, I hear some of the candidates say, if I say the right things, my body language doesn't matter. Actually, we are testing non-verbal as well as verbal. And there's something, well, and I made it up. I call it false empathy, where you go, oh, I'm sorry. Oh, by the way, do you smoke? I mean, it doesn't connect. You know, you don't pretend. If you can't be empathic, don't do it. Don't pretend, is what I would say. And active listening is a really important concept. You might say to me, what do I mean? What I mean is not repeating questions you've already asked, because that doesn't look very well with the patient. I've already told you that. So it's well worth thinking about when you are videoing your consultations with your patients and things. Look at yourself, your tones, your facial expressions, your body language, etc. And again, there is some idea amongst trainees that I've got my favorite consultations, I'll do that. Actually, we're looking for flexibility and adaptability. By the way, one of my trainees said many years ago, Anwar, why are there so many consultation models? He said, because you can pick various things, but each model has an area of strength. So if your favorite approach, neighbor, for example, there, Roger, I'm promoting your model because only 5 bits on it and you got used to it. If it doesn't work, you think, what's happening? Do I need a much more transactional analysis approach? But if you haven't got all those models in your head, or you know about them, you're not going to use them, are you? You're just going to go down the same alley saying the same thing. So I do think how you consult with an anxious patient differs from a professional discussing health screening. You've got to adopt your style. And that's what we want. And we are looking for varied consultation styles. Please don't rush through cases because you're running out of time. What I often say in the last minute, say, look, we're not going to finish everything I want to say. Let me just summarize what I do want you to do. This, and this. Yeah? And at least you've got it there. But don't forget safety netting. Don't forget follow-up. So that's, I mean, I started with the SCA first because the SCA is probably where the biggest misconceptions is. With the AKT, it's not a knowledge. It's the AKT stands for Applied Knowledge Test. So it's the application of knowledge, not just recall. So there's no point knowing the nice kind. It's how do you apply it? Well, how do you test that? You see lots of patients. So my registrar, there's one now at the moment doing his AKT in June. We're saying, do you know what? At the end of every surgery, pick out the patients that you had to look things up. So, and it's just 3 patients you had to look up different things about. Just pick 1 to read. Because you're not going to read 3. Let's be honest. And don't spend more than 15 minutes reading it. Write it down, 2 or 3 bullet points. And if you do that every day, you've got all the topics that are common things are common. Yeah. You might get caught out in a rhabdomyosarcoma, but you'll probably only get 1 question in 10 years on it. Yeah. Common things are common. Everyone talks about statistics being hard. It's actually quite straightforward. There's a lot of stuff in stats you can't test. And the other thing is, if you're vaguely aware of it, you've got the answer in front of you, haven't you, in the AKT? And what a good examiner does is has distractions for people who are guessing. So what do? You cover these distractors, see if you can answer it. If it is, great. If you can't, then you think about it. So I call it the cover test. In fact, the AKT group have written some fantastic guidance. But I do think knowing basic stats, what prevalence, etc. means, mode, etc. That's all you really need. You don't need to really know too much. You probably do need to know pros and cons of different study designs, but that's about all, really.
For somebody who is training a trainee, what are the things that you have noticed are really effective that separates a good trainer from a great trainer?
That's a very interesting question. I do think, just like I was talking about trainees adapting to patients, the trainer that adapts their teaching style to the learning style of the trainee is what we need. We do not want people saying, I will never use didactic training, a didactic approach. Actually, there's sometimes you do use a didactic. So the way I tend to describe it, we all talk of heuristic teaching style where you go and find out things and you learn through that journey. But in order to do that, you've got to walk around and find out, isn't it? Now, the way I tend to, as you probably get to see me, the more you know me, Erwin, you'll find I have metaphors. So I think of as without patronizing, I think of trainees almost like a journey of a child growing up. So in the initial stages, they can't go and forage for food. You have to feed them. That's your didactic learning, isn't it? So it depends what's now. If you're still feeding them when they're walking, that's a bit wrong. Yeah. So, and I do think you're going to use the right method for the right stage of training. But also you've got to adapt because people will learn in different ways. I mean, my wife is a very audio learner. She has podcasts and all. Whereas, you know what? When I'm driving, I want to listen to my classical music, and I don't want too much stuff in my brain. I'm a simple chap. But I will research to the nth degree. You know, if someone says to me this, I'll say, why? Look things up. So the different styles of learning, I'm much more of a theorist, and we need to get people doing that. And you'll find that, and I don't know if you've used various learning style models, but you know, it's really important to work out whether an activist or a theorist or a pragmatist, etc. Because you need to connect, and maybe that's the word, connect. So you need to connect with the trainee, not only in understanding what their learning style is, but also on a social nick. I remember there was when I was head of school for GP training a decade ago, I came across a doctor who'd failed the CSA, in those it was the CSA, maximum amount of time. So it was really an exit interview. And I said to her, tell me your journey. Apparently no one had ever asked about a journey. I'm going to summarize it because I know time is short. She said to me, oh, I got the gold medal in Dor Medical, which is one of the top universities in Karachi in Pakistan, actually. So I thought, that's a terrible lady. Why is she failing? And she came here, was doing medicine, just failed the MRCP and didn't really want to resit it again because it was just pride. And then someone said, you know what, be a GP. You can drop your kids on the school run. It's really nice, family friendly. You can do as many sessions you want, you know, all the great stuff of primary care as well. And she thought it'd be a doggle. Actually, it's not, is it? General practice is on the coalface is hard work. And the biggest problem she had was so the AKT, she did a really good pass. And that's why that's what led me to think, tell me your journey, because there's a discrepancy in the AKT score and the CSA score. And I said, well, tell me about when you see patients. She says, I don't understand this shared management. Why should I share I know what to do. I know what's safe. I know everything. And she did. She was a very clever lady. She was in the wrong career. And I do think, you know, there are people who have got stuck into primary care for the wrong reasons, and they probably just need to reflect why. And by the way, she's doing really well as an SAS doctor in medicine. She's done fantastic. So I think there is something about connecting both with the professional bit of the teaching learning style, but connecting on the social bits as well. I mean, I'm really proud that a lot of my trainees I'm still in touch with, even now nearly 30 years later. So no, it's 30 years, yeah. So, you know, and I think there is something about the joy of being a trainer. You actually have a friend for life. I mean, I've stopped seeing my trainer 5 years ago, but before that, I used to see him quite regularly. And I do think it's a privilege to being a trainer, to be part of their journey. Yeah. And in fact, it's important because actually one of my ex-registrars is my current GP. I wouldn't have him to look after, would I, if I hadn't trained them? But also, no, to be honest, being a trainer is a privilege in that you're part of that journey, but they've done all the work.
The reward you get from seeing somebody from a place where they are just about to start to where they've accomplished a lot and see that journey, the transformation is really rewarding. I agree with you. and the friendship as well, lifelong friendship, is really quite significant. And I think what you're saying here is that, to me, you strike like you really enjoy doing it. But I have also noticed some trainers, they don't really get that much joy, and for them it's just like a job when they do it. um, but I think there is also other things going on where the stress of being a trainer is the workload as well. How do you advise a young trainer who is just started and have a really difficult um, trainee at the moment who's struggling?
When people sometimes say Anwar's a good trainer, it's not because Anwar's a good trainer, it's because Anwar's colleagues provide enough support. Because I'm literally there 2.5 days. Yeah. And in my practice, the trainer's grant goes into the practice, because let's be honest, support and my partners and my colleagues, salary doctors, majority are into training. We do medical students as well. So training's inculcated. In my first practice, maybe I was the only one that was a trainer, and it took a while for people to understand that training isn't something you sit down. I mean, my friend who brought me into general practice, he's now passed away, rest in peace. He was a lovely chap, but he never really understood that training was also an important role. He thought, actually, Anwar, you just sit there and talk. That's not real work. The real work's the patients. So I think if you get not full backing from your colleagues in practice who appreciate that training is a reasonable, shall we say, way of working, then you'll be recognized for that. So I have 2 trainees. I have 2 sessions that I teach them, because we recognize you can't. And again, I'm shocked at the number of trainees that say, we never have a one-to-one tutorials, we have joint tutorials. How do you cover some of the individual issues if you have joint tutorial? I don't understand that. And I do think, yes, you're right, we don't get paid a lot for other trainers grant, but we do get a bit of labor. And yes, it's not economically as if, you know, you did locums, or not, there are any now. It's not a money-making exercise, but it is a privilege. It does, by the way, keep the standards up. It keeps you on your toes. Therefore, you as a doctor will make sure that you'll provide the best care to your patients. And for me, being a training practice is an impetus to keep your, shall we say, your work rate, your standards up. But in order to, you can't do that on the quiet. Yeah, you've got to put some effort and some time into it, and that does mean one-to-one tutorials. There are sometimes we may do joint tutorials when there's a joint need, but it's very rare. I've never really liked that, because I do think, and also the other thing I do, because I've got a session for that trainee, I say to them, if you don't do your portfolio entries, don't bother coming to me, go somewhere else. And every week I have a look and say, there's been no entries last week, but were you busy? Were you okay? Because contemporaneous entries makes life so much easier. And the other thing, I have a structure in that 1 week we do COTS, 1 week we do CBDs, 2 weeks we do topic-based tutorials. So by definition, they've got 3 times the minimum of COTS and CBDs already. I expect a minimum 1, if not 2, learning logs, because they've got an educational half day to do it in. I don't give a damn how to do it. But what I do say to them, you can't fail a log entry. And if you spend lots of time preparing for it, you make me unemployed. If it's a quick 10, 15-minute brain dump with some reflection, I can then give you advice how to improve it, can't I? All right? So don't make it too perfect. But if you're not making too perfect and it only takes you 10, 15 minutes, you've got no excuse not to do it. And I never, ever look at entries outside the tutorial time. That's why, for me, being a trainer is not a problem, because I do it within. I've got 4 hours, 10 minutes. So I start off with hot topics. How are you getting on? Has anybody given you feedback that they shouldn't have done? Because all feedback should come through me, not everyone giving feedback to my registrar. I'm very possessive, by the way. So we start with hot topics. How are you getting on? Any difficult conversations, and they send on tasks. We go through that. Then we go through the agenda of the day, whether it's a COT, CBD, or a topic. Yeah. And then we're finishing by going through the log entries. And at the end, we decide what we're doing for next week. So, you know, and let's be honest, you can cover that in 3 or 4 hours. That's your session, is it not? And I've got a feeling what's happened, and I do know one trainer who used to keep the trainer's grant, and quite rightly, the partner said, well, you deal with it, not me. So he's getting stressed out. Yeah. And it's not a lot of money anyway, so you might as well share it and just take a portion of it. But because you want to give a good job. And I do think, oh, that's the other thing I would say. Primary care, whether you're a GP, trainer, examiner, whatever, it's a marathon. Pace yourself. Yeah. And I suppose for me it's a bit different because I've finished my marathon. I'm doing my lap of honor, and lap of honor is never tiring, is it? So maybe I'm the wrong person to ask about the stress of being a trainer, because for me, I'm doing my lap of honor. I'm enjoying it, and it's an absolute privilege. At my age, if someone listens to me, it's a great sign, isn't it?
Quite inspirational. Still doing it and you enjoy it. What would you like people you've trained remember you looking back?
Fair, appropriately kind, not too kind, by the way, because you can kill people with kindness. Yeah, fair. Maybe they could go out for a drink with me. That would be quite nice. Yeah.
Thank you so much for sharing your wisdom today, Anwar. Is there anything that we haven't touched that you might want to say, or any last piece of advice to a trainee who's listening?
The main thing I would say is, trainers, if you have a low opinion of primary care at the moment, you will impart that to your trainees. And I really would suggest, have a think about it. The great thing of primary care, and I've been in primary care nearly 3.5, 4 decades, is it has an amazing resilience. It will bounce back, no matter what the governments of the day try and do, or the bureaucrats. Stay positive and impart that to your trainees. Second thing I will say to trainers is, it is a privilege being a trainer. And the third, I probably would have retired 4 or 5 years ago when I should have done, if I wasn't a trainer. But I think it's my trainees that keep me working.
That's outstanding. Great. Thank you so much for sharing your journey with us. Where can people find more about your work?
Well, no, I'm not sure I'm that good to for people to look me up. I'm not sure. But what I would suggest people do think about is EDI, equality, diversity, and inclusion. And they should think of that in everyday work as a doctor. And if they are in education, and that's one of the things I'm proud to be associated with UEL, is that UEL is really aiming for good student experience, but addressing inequalities. And for me, you know, the first step to addressing inequalities in health is actually addressing inequalities in education. And by the way, as a final note, the word doctor comes from the Latin docore, to teach. Your job is to teach your patients. And let's address health and education inequalities together.
What was the number one takeaway you got from this conversation with Professor Anwar Khan? Write it down in a comment. And if you found this video useful, you might want to watch the next video with Roger Neighbor. Click here to watch it. I'll see you on the other side.